Hello and welcome. I'm your host, Neil Howard. Thank you so much for joining us for another segment of Health Professional Radio. We'll be speaking with Dr. Avery Ince in this segment, Vice President, Medical Affairs, Cardiovascular and Metabolism at the Janssen Pharmaceutical companies of Johnson & Johnson. He's joining us this morning to talk about the American Heart Association and the American College of Cardiology's release of their 2023 guideline on the management of patients with chronic coronary disease, including CAD. Welcome to Health Professional Radio. Dr. Ince, thank you so much for joining us.
Good morning. Good morning. Thanks for having me.
Well, tell us a bit about yourself, if you would, and talk about your role at Janssen.
I trained in internal medicine and endocrinology at Massachusetts General Hospital in Boston, and I joined pharma right around 20 years ago, a little under 20 years ago, and I'm currently Vice President of Medical Affairs for the cardiovascular group, which basically means that I run a team of approximately 100 people altogether, some of whom are cardiologists, many of whom have PhDs or PharmDs in some sort of biomedical science.
Now, it's my understanding that these new guidelines having to do with coronary artery disease have some specific compounds that are recommended. First of all, could you tell us what coronary artery disease is and how does it affect someone's life?
Yeah, absolutely. So first of all, coronary artery disease, in the main, constitutes a narrowing of the blood vessels in the heart. So it's a narrowing of the coronary arteries. And, of course, these are the arteries that are supplying blood to the heart itself. When you have a narrowing of those arteries, then you have a reduced supply of blood to the heart, consequent damage to the heart tissue, and that can result in ischemic events, myocardial infarction, also known as heart attacks, etc. That narrowing of the arteries is as a consequence of something called atherosclerotic plaque. And, when those plaques are formed, then eventually they can rupture, and then that can lead to all the badness associated with heart attacks, etc. So that's what CAD is. And it, of course, in the end is it's a pretty prevalent disease in the United States of America. Of the order of 9 or 10 million people have coronary artery disease. And, of course, the morbidity and mortality is substantial as a consequence of CAD.
Is the patient the first to know based on some common symptoms?
It's not at all uncommon for patients to be symptomatic. Both symptomatic presentation of CAD and then also CAD in the absence of symptoms, those are both commonplace. In terms of the symptomatic presentation, probably the most common would be some sort of chest pain or chest discomfort. Some people describe it as a chest tightness. Sometimes you have some sort of radiation of that pain, so you can have discomfort that can be in the arm or, in the jaw or in the neck. There are variants on this. There are some people who present not so much with pain, but in the case of something called inferior MI, present with, nausea or sometimes even nausea and vomiting. But I would say that generally speaking, the typical symptoms would be chest pain, arm pain, jaw, neck pain, and then, of course, you can have associated lightheadedness or shortness of breath, etc.
So there are a lot of symptoms that are symptoms of totally unrelated conditions as well. How often is it misdiagnosed?
You're exactly right. There are a large number of people who experience some of these things, sudden onset nausea or vomiting or chest pain, chest and arm pain, etc. There are a number of people who experience these things, somewhere in the outside world, while mowing the lawn or while shoveling snow or some other thing, sometimes at rest. And then who make their way into the nearest emergency department with, concern that they might be having a heart attack, that they might be having some sort of ischemic event. And it turns out that there is a common protocol within these hospitals, within the emergency rooms. It's called Rule Out MI. And basically there are a battery of tests which need to be done. You do an EKG and, you do some blood tests. And the reason for which this is done is because a fairly substantial fraction of the people who present an ED with chest pain, in fact, have some sort of gastrointestinal problem. or they have some kind of pulmonary or lung problem, or perhaps there's a problem with some of the muscles that are in the chest wall. So there are a lot of things that present with chest pain or chest tightness or chest discomfort, only a small fraction of which are actually cardiac in origin, and that's the exact reason for which you need to undergo this kind of testing to make sure that it's not cardiac rather than something else. If it is cardiac, then of course immediate treatment for chest pain of cardiac causes is necessary.
Now, the American College of Cardiology and the American Heart Association, as I said in the outset, recently published some new clinical practice guidelines for the management of CAD. What are these new practice guidelines?
I guess guidelines in general are recommendations that are based on the best and the most recent scientific evidence for physicians and other practitioners to assist them in the best possible care, best possible management of their patients. It turns out that in cardiology, that the American College of Cardiology and the American Heart Association, that they are two of the best respected, largest and best respected professional societies for cardiologists. And so there are a number of people who are very keen to understand what recommendations based on the evidence these organizations are making that will help, physicians and other healthcare practitioners manage patients with coronary artery disease, or what is now being called by ACC and AHA chronic coronary disease, CCD, which I think is a really important change that I'll say something about in a minute. So that's what the guidelines are. The guidelines are basically an attempt to help physicians and other HCPs adhere to best practices in the management of their patients. And with respect to these most recent guidelines for the management of chronic coronary disease, one of the big developments that has just happened in recent weeks is that low doses of rivaroxaban or XARELTO have actually been recommended for the management of patients with chronic coronary disease. They've been deemed to be reasonable in the management of certain high-risk patients with CCD.
How will it impact the future of CAD care specifically from what the standard of care has been thus far?
Well, we're hoping that this winds up having a very major impact. This particular change to the guidelines has basically been driven by really strong data that were generated in the COMPASS study, COMPASS trial about 5 years ago, I guess in 2018, plus or minus. And those data indicated that the addition of low-dose rivaroxaban, 2.5 milligrams twice a day, the addition of low-dose Riva to daily aspirin actually has a pretty substantial impact in terms of reducing, major cardiovascular events. In other words, when you add low-dose Riva to daily aspirin, you wound up seeing as much as a 42% reduction in stroke as compared to those who received standard of care, including aspirin. You saw a 22% reduction in cardiovascular death, and you saw an overall 24% reduction in major cardiovascular events altogether. So that's a pretty substantial improvement in the management of patients, and that was as a consequence of the addition of low-dose Riva 2.5 twice a day to aspirin. And so, we think that if that were to happen for larger numbers of patients, then that's something that would constitute a substantial advancement in their care. I should just mention, just very quickly, that your typical physician, when confronted with a patient who has chronic coronary disease, is concerned principally with doing three things. Number one, with controlling blood pressure. Number two, with controlling elevated cholesterol. And then number three, with basically sort of managing what people like to call angry platelets. So in these comments now, I'm not addressing either the blood pressure control or the lipid control, but rather what to do with these platelets. Historically, many physicians manage these with daily aspirin. Some manage with aspirin and some additional agents like generic clopidogrel. And the import of this data is that rather than managing patients just with aspirin, you can achieve a dramatically improved result if you were to add low-dose rivaroxaban. So we hope this winds up having a big impact on the management of patients.
Well, Doctor, I appreciate you joining us here on Health Professional Radio. Hopefully you'll return and give us some more information on XARELTO, these new guidelines, and any further developments based on any other research that you conduct. Thank you so much.
Thank you. I appreciate it.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Avery Ince. Audio copies of this program are available at healthprofessionalradio.com.au, also at Anchor, Spotify, and be sure to subscribe to our YouTube channel at youtube.com/Health Professional Radio.